Hello, everyone. My name is Meghna. I'm going to be running you through all of your opthal content for year three. Um, as you know, ophthalmology is not a big part of your year three matrix. So what I would like you to focus on is basically just understanding the broad brushstrokes, being able to differentiate between certain conditions based on how they present in terms of, does this one have pain? Does this one have a red eye? There's a lot of unfamiliar terms in ophthal as well, which take a little bit of time to get your head around. So feel free to revisit this lecture as many times as you'd like and take some time to recap your ophthal anatomy as well, because that's quite helpful. So today's topics, we'll just have a brief overview of your anatomy and then move on to covering your infections, your inflammations, and some other things. Now, just note that there's only two R1s in ophthal, conjunctivitis and cataracts. Hopefully, these are words that you've heard before, but we will cover them as well as all the other R2s and R3s. But yeah, focus on the high yield stuff and focus on being able to recognize what a condition is, because that will help you in figuring out management. But overall, ophthal is quite intuitive as well. Okay, so a very overwhelming slide. I won't really go through it, but feel free to pause this and take some time to recap in your own time. I always get confused between the chambers and the humors, so I'm just going to cover this very quickly for you guys as well. So there's basically three chambers. Your vitreous chamber is in the back of the eye, and it's this huge area here. It holds your vitreous humor. And when we talk about humor, it's like a jellyish, liquidy thing, and it exists in this back chamber. We also have aqueous humor, which exists in the anterior and posterior chambers. And aqueous humor is separated from the vitreous humor by the lens, which is just here. And this is see-through, ideally. So those are your three chambers. Now, talking about conjunctivitis. Conjunctivitis is basically inflammation of the conjunctiva. What is the conjunctiva? So the sclera is this white layer going all the way around the eye, and this clear bit on top is the conjunctiva. So you'll see that the conjunctiva is only on the exposed part of your sclera. It doesn't go over your cornea, and it also goes up on your inside of your eyelids. Okay? So your conjunctiva gets inflamed, which gives you conjunctivitis. It presents with this red eye, itchy, gritty sensation, which is especially the case in allergic conjunctivitis. There's discharge, and the discharge is purulent, so it looks like this, even bacterial, and watery in viral or allergic. It can be bilateral, but often it starts off unilateral and then spreads to the other eye. And how does it spread? It's really, really contagious. So rubbing your eyes or using a pillow or something can help with the spread of pathogens. Lasts for a few weeks. Importantly, there's no vision loss, no photophobia, not really any pain that should be associated with conjunctivitis. So etiology, like we've touched on, there's bacterial, viral, allergic. Viral is really common. It's basically associated with like any other viral illness, often seen with respiratory tract infections. Bacterial is a bit more serious, requires treatment with antibiotics, but we'll get to that. There's a number of pathogens, Staph, Step, Pseudomonas. The management is quite similar. Can also be chlamydia or gonorrhea as the pathogens causing this, but this is associated with an increased risk of vision loss. And we see this more in indigenous populations and in neonates. So that's also quite serious. Allergic Conjunctivitis is basically like what we get with hay fever. We can get it with other triggers like dust or something year round as well. But the treatment is different based on what the etiology is. So if it's viral, it's conservative. It'll resolve on its own with the viral illness. The bacteria can be treated with antibiotic eye drops. So chloramphenicol is what you would have heard of before. It's called Chlorcig as well. Chlamydia, gonorrhea, we would do a swab and then manage accordingly with antibiotics. Allergic conjunctivitis, we treat with antihistamines, and they're topical as well, so eye drops. But overall, we want to encourage hygiene and minimize spread. So you don't want it to go from one member of the household to another. We have this interesting finding, which I used to get confused between. So there's papillae and there's follicles. Basically, because your conjunctiva extends to your inner eyelid, we have this sort of cobblestone appearance, and cobblestoning is a bit of a buzzword. It's more common in bacterial and allergic infections. Comparing that to follicles, so follicles are seen in viral and chlamydial infections, and you'll see the follicles are a bit more sort of grayish, see-through-ish, while the papillae are a bit larger as well. But basically, don't need to differentiate between them. Just recognize that this sort of phenomenon exists with conjunctivitis. Okay, moving on. Blepharitis. Blepharitis is inflammation of the margins of the eyelid. So this presents with this sort of crusty buildup on the base of your eyelashes. It will give you itchy, gritty, dry eyes. Usually it's bilateral, might have some red eyes with the inflammation and irritation. Like we said, crusted eyelashes, might have a foreign body sensation, could also extend to the eyelid and give you a bit of a swollen eyelid. But importantly, it's associated with seborrheic dermatitis, okay? Etiology, so basically there's these glands, meibomian glands, which secrete oil onto the surface of your eyes. And if these are dysfunctioning, we get blepharitis. And that also explains this association with these recurrent dry eyes and the dermatitis. Management is conservative, so keeping the area clean, a bit of warm water, avoiding eye makeup to not irritate further. Okay, now we talk about hordeolums. So there's two types of hordeolums. There's an external and an internal. An external hordeolum, so this phenomenon is not actually to do with the eyeball itself, but with the lid. Okay, so this is a stye if it's external, and an internal one that exists by pulling down. Okay, hordeolums are tender red lumps. They can be purulent. External hordeolum is an infection of this gland of Zeiss or glands of mole, doesn't really matter, but basically infection, which is why it's tender. While an internum is an infection of the meibomian gland that we talked about before. Okay, this can be compared to a chalazion, which also looks like a little lump here, but it's painless, okay? And it's caused by the blockage. So these are tender because they're infected. Management is quite similar for both. Again, keep it nice and clean. A gentle massage of that area can help to clear up the obstruction or infection. Usually resolves in a few days. Okay, keratitis. So keratitis is the inflammation of your cornea, and this often happens from various pathogens. So we worry about bacterial keratitis or microbial keratitis, which is caused by contact lenses often, or associated with contact lenses, and especially poor hygiene surrounding these contact lenses. So sleeping with lenses in, or not changing them often, or going swimming with your lenses in. You're introducing pathogens that can erode away the cornea, cause a scar or an ulcer. But it can also be caused by other corneal trauma, foreign body that introduces bacteria that way, or dry eyes. How does this present? It's unilateral, painful red eye. You have trouble seeing, so reduced visual acuity, might have a bit of photophobia, a bit of purulent discharge because it's bacterial. The cornea might look opaque, okay? And there's this phenomenon called a hypopyon. So a hypopyon is basically a buildup of white blood cells or pus in this anterior chamber, and that's literally like just settling at the bottom of that chamber. We can see a defect in the epithelium by dropping a little bit of this drop called fluorescein. And if you look at it under blue light on a slit lamp, you'll see that it lights up. We can consider doing a corneal swab or a scrape, and we treat this with topical antibiotics. So chloramphenicol is Chlorseq that we talked about with conjunctivitis, or ciprofloxacin. Viral keratitis is caused by VZV or HSV commonly. We often see a past history of infection with these viruses or past history of keratitis with these viruses, or we might have immunosuppression that makes you more susceptible to having a viral outburst. Okay, presents similarly with a unilateral painful red eye, reduced visual acuity, photophobia. But when you look at this ulcer or when you look at the eye under the blue light with the fluorescein uptake, we might see some specific findings. So if you see your patient's eye looks like this is called a dendritic ulcer, and it's associated with HSV. Okay, a Hutchinson sign is basically these vesicles on your nose, so they have quite specific signs. Okay, we treat them with the appropriate antiviral ointment. Why do we want to get keratitis treated? It can cause further spread of your infection, can cause corneal scarring, which would cause permanent eye damage, basically. We can have cataracts with increased inflammation and glaucoma, and we'll talk about those two in a bit. And very scary, we can have a corneal perforation, which we don't want. Okay, moving along, uveitis. So another itis of another part of your eye. I get really confused, so this is another reminder. So there's various layers of tissue everywhere. Uvea is this reddish layer that extends all the way from the front. So it goes from your iris to your ciliary body, and then it goes and becomes this middle layer between your retina and your sclera, and it's called a choroid when it's at the back. Okay, so it's an inflammation of your uvea, and it can be along any part of this uvea, but we'll basically be talking about anterior uveitis, which is iris and ciliary body. Okay. Etiology. So it's associated with a lot of autoimmune conditions. So if there's a question stem with a bunch of autoimmune stuff, or a patient's had an infection or trauma, you might think about uveitis. How does it present? So it presents with eye pain, which is more dull and aching rather than sharp. You might have a bit of red eye. But importantly, we're looking at different layers now, so it's not going to be affecting your sclera at this point. Okay, have reduced visual acuity and photophobia, increased tear production called lacrimation, can be acute or slow onset depending on the etiology. If it's an autoimmune thing, it might be a bit slower. We have a constricted pupil because it's affecting your iris, so your iris's ability to contract and expand is jeopardized. And interestingly, we have this irregular shaped pupil, which is caused by inflammation, and that causes adhesions, and they sort of pull on the iris in different ways and gives you this irregular shape. You might also have a hypopyon, and there's this phenomenon called a ciliary flush, where it's redder around the iris, which makes sense. Management. Oh, sorry, there's another finding as well, keratitis precipitates, which you might see. Management, basically you want to get ophthalmology involved quickly, treat it with drops that dilate your pupils, and that reduces the pain associated with your iris ciliary spasm. We have topical steroids that can be given to reduce the inflammation. and manage the autoimmune systemic disease that might be part of the etiology. Now, with steroids, the reason I've written raised intraocular pressure is because steroids can sometimes cause, or we worry about, a raised intraocular pressure when giving a patient topical steroids. We'll cover that later. Episcleritis. Now, this is a lot less scary. It's talking about the layer above your uvea called your sclera, and the sclera extends all the way from the front to the back. Okay, but importantly, it's the top layer or the top part of your sclera called your episclera. And this is quite self-limiting. It's less severe than scleritis, which is an inflammation of all of the scleral layers. So it's doesn't go down as deep, I guess. It's quite common. You see it with young adults, and it's associated with inflammation, autoimmune disorders, but not necessarily. Often it's just sort of a thing that's there and we don't know why. Kind of looks like this red eye, acute, unilateral. It can be localized like this, or it might just be diffuse all over. You can also have this thing called a nodular episcleritis picture, where you can see a very distinct area. Might be a little bit of pain, but it can be painless. Importantly, there's no reduction in your visual acuity, no discharge, no photophobia. And these are signs that might point you more towards scleritis. You can do this little test where you drop some phenylephrine into the patient's eye, and you might see a bit of blanching of the vessels. Management, like we said, self-limiting, lasts for a few weeks. We can consider some analgesia or eye drops. The patient is a bit uncomfortable. Steroids, if more severe, but basically steroids are used for scleritis more so than episcleritis. And scleritis is one that needs ophthal referral. But you don't need to know about scleritis at this stage. Cataracts. So cataracts are lens opacifications. So when we talk about a normal lens, we have this patient here with this clear lens and all the light can get through. But as time goes on, someone's lens might get cloudy for various reasons. And then that sort of, it's basically like looking through a foggy lens, right? Or like a not clean, if you wear glasses, like your glasses aren't clean or something, but a lot worse. So etiology, the vast majority of cataracts are age-related, and they might also be caused by some other things, like if patients had inflammation, post-trauma, or uveitis or something can predispose them to cataracts. Smoking, diabetes, metabolic syndrome, medications like steroids, interestingly, radiation, which increases your UV exposure. And it can also be congenital, but that's something you don't need to worry about at this stage. It comes up next year. Presentation. So this will look like a unilateral progressive reduction in your visual acuity. And it might look like this blurring picture where the whole of your vision is sort of a little bit fuzzy. There's not really any progressive vision loss from certain parts, or like a change to your visual field. A patient might say that they have glare, or they have halos around lights, especially at night, might have a bit of difficulty driving. Might be some issues with color distortion, but importantly, it's not a painful disease. And you might see a loss of red reflex on examination, where we shine a light into patient's eye. And that's more so the case with severely opaque lenses. So like this patient here, you can see that their right eye from far away, you can just see that there's a cataract sitting in there. Management. So if patients having difficulty seeing or driving at night, avoid night driving. But ultimately, this can't be reversed. We can't undo the opacification. We might consider treating the underlying cause, like if they've got diabetes, or stopping steroids or whatever. But ultimately, the hallmark of cataract treatment is a cataract surgery. It's very safe and very common procedure where an ophthalmologist removes the cataract. So the old lens is taken out and a new lens is put in. And that new lens is plastic. It's not a transplant from another patient. It's very common. Like I said, low risk of infection. and a patient might need to have both of their cataracts replaced at one point or another throughout their life. Okay, glaucoma. So glaucoma refers to a change in the pressure inside your eye. So if we've got a whole bunch of this humor, like we talked about vitreous humor, aqueous humor, there has to be, a range of tolerable pressure. And so in glaucoma, that pressure increases. There's a few different mechanisms behind this, but if we talk about the anatomy and how it basically works in general first, so you have a ciliary body here, which produces your aqueous humor. That aqueous humor flows out. So if we follow these blue lines, flows out to the front, the anterior chamber, goes around through the trabecular meshwork and gets drained out. And that's just normal. Like we all have that happening in our eyes at the moment. But sometimes what can happen is that this part gets blocked off. If your iris sort of pushes forward, blocks that angle, it's a closed angle. And so pressure builds up, and that's one type of glaucoma. And this is what we'll cover first. So that's called acute closed angle glaucoma. There's a raised intraocular pressure due to a closed angle between the cornea and the iris, and it causes a very sudden onset of symptoms. So normal intraocular pressure is 10 to 21. With this acute closed angle glaucoma, you can see pressures going up to like 40 and stuff. So it's very sudden, and it means that this is a huge emergency as well, because there's a risk of permanent vision loss. So if we think about pressure increasing, building and building and building, we're putting pressure on the optic nerve, and once that damage is done, it's really hard to undo that damage. Okay, risk factors for acute glaucoma: age, past history of acute glaucoma or family history. Females are like 4 times more at risk than males. And recent use of pupil dilators. So if we think about your pupil dilating, you're basically putting yourself more at risk of like this closing up, right? Not to say that we don't use pupil dilators, they get used all the time, but just something to consider if we're thinking about why this patient might have closed angle glaucoma. Certain meds can do it as well. Presentation. So it causes a sudden, unilateral, very painful red eye. It's associated with headaches, nausea, vomiting. It looks like this on a patient. They might see halos around lights, reduced visual acuity because there's a whole bunch of pressure in their eye, which is compressing the optic nerve and blurring their vision. And you'll see this patient has a fixed mid-dilated pupil. So if we compare it from this side to this side, their left pupil is a lot more constricted than their right pupil here. And that will be fixed, so it won't change based on how much light we're shining, right? And you can see the cornea looks hazy. And if we felt this patient's eyeball at the moment, it might be a bit hard on palpation, because we've got extra pressure building up in there. So what can we do? We can use this thing called a gonioscope and visualize the angle itself and confirm that it looks like it's a closed angle. We can do tonometry, which is if you've been to an optometrist, they like shoot a little puff of air onto your eye and check the pressure that way. And that's just to quantify if this patient does have raised intraocular pressure. We manage this very quickly. It's an urgent referral to ophthalmology. We can, interestingly, patient lying supine is something that apparently helps in this condition. Pharmacologically, you'd want to consider pain relief, antiemetics because you're feeling nauseous. There's acetazolamide, which can be given IV, and this reduces the production and sort of stops, or not stops, but reduces the buildup of pressure in one way. Or you can give pilocarpine drops, which cause pupil constriction, and we hope that like that physically opens up the angle that's blocked up at the moment. Or we can give timolol drops as well, which just reduce the pressure like any other beta blockers do with the blood. Definitive you can do this procedure called a laser iridotomy. So in a laser iridotomy, what we're doing is we're just making a little hole in your iris, and that allows for the fluid to pass from the posterior to your anterior chamber. So even if it gets blocked up, we're not going to have that sort of acute closed angle glaucoma picture. And that's what it looks like when it's done in person. Okay, the other type of glaucoma. So like we said, this is a pathology that we're seeing here. This is what it normally looks like. And this is also what open angle glaucoma looks like. So in open angle glaucoma, nothing really changes except for the increased resistance in the trabecular meshwork. And that means your aqueous humor isn't flowing out as quickly, and so slowly but surely pressure keeps building. So raised intraocular pressure caused by increased resistance of aqueous humor through the trabecular meshwork, and this over time causes damage to the optic nerve as well. And this happens over like months and years. Etiology is, risk factors, increasing age, family history, myopia, diabetes, Graves' disease, presentation. So it can be asymptomatic. Patients might not notice it for a long time because it's progressive peripheral vision loss, very slow and gradual. So a patient might not realize that they're losing their peripheral vision until it's quite compromised, right? So it can be asymptomatic initially. The patient might report headaches or blurry vision, halos around lights. And when you take a look inside at the back of their eye, you might see this disc cupping phenomenon. So this is what a normal optic nerve should look like. But here what we're seeing is that the optic cup to disc ratio has changed. And that's caused by increased pressure in the back of the eye. Okay. So what do we do to check? We can do tonometry to quantify the intraocular pressure, and that's good for monitoring this condition over the months and years that a patient might have glaucoma. We can look at the optic nerve for cupping with a fundoscope or a slit lamp. We can visualize, we can quantify the visual field defect, especially because it's peripheral vision loss. We want to track how bad it's getting. And we can, again, check the angle with gonioscopy. Management. So we have this, the first line, you might see this drug called lantopros, which is a prostaglandin analog. And again, it increases the outflow. So it reduces that resistance in the trabecular meshwork. Timolol, again, gets used in open angle glaucoma as well as closed angle glaucoma. And then surgically, we can do a procedure called a trabeculectomy, where basically we're creating this new pathway for aqueous humor to flow. Because if you remember, open angle glaucoma is increased resistance through the trabecular meshwork. So we're just making another pathway. And that keeps the pressure down, hopefully. Okay, our last condition for today. So retinal detachment. So basically retinal detachment is where the retina separates from the layer beneath it or behind it called the retinal pigment epithelium. So you can see that retina moving away from the back of the eye. There's various types of retinal detachments, or I suppose etiologies. So if we talk about regmatogenous retinal detachment, you can basically that causes retinal tears. And what we're seeing here is that because the tear is there, the vitreous humor that exists in the rest of your eye is going and flowing to the back of your eye through that tear. Sorry, my mouse just glitched for a second. So basically we've got this vitreous humor in there, right? It's not just air. And that vitreous humor goes through the retinal tear and builds up at the back. And then that sort of keeps growing and worsening the retinal detachment. That can be caused by myopia. So sometimes your eye is shaped in such a way that predisposes you to tears. Previous posterior vitreous detachment can cause a tear, which then causes retinal detachment, or ocular trauma. And this is another picture showing the tear there. Exudative, so subretinal fluid can build up fluid under the retina can build up from various pathologies, tumors, uveitis, and that's another way you can get retinal detachment. And finally, there's tractional retinal detachment, where we're having changes to the actual membrane. The retina is scarring, and basically that contracts and detaches the retina away from the posterior membranes. And you can see that in proliferative diabetic retinopathy and other proliferative pathologies that we don't really need to worry about today. Trauma as well can cause that. Patient will say that they're having this painless visual field loss. So sometimes it's described as this sudden curtain coming down, or a shadow coming down. And it's very sudden because the retina has just suddenly detached away, Flashes and floaters. But other than that, there's no red eye because we're talking about the back of the eye, and there's no pain. Management, basically you refer it to ophthalmology quickly because we want to re-establish blood supply to the retina. The retina, when it's lifted away, doesn't have proper blood supply. And this is neurosensory tissue. It's the whole way that our eyes can pick up light and sight. So if we're not fixing that, it can lead to permanent vision loss. How do we fix it? So we can repair the tears with laser therapy, cryotherapy, and we can reattach the retina with vitrectomy, or this other procedure called pneumatic retinopexy. So that's retinal detachment. This is an R3, so don't worry, just recognizing that it's a curtain that sort of comes down and it's painless. Good luck. Don't worry too much. There's a whole lot of information in ophthalmology and a whole lot of new words that you might not be familiar with. And it can feel like a lot of the conditions sound quite similar, difficult to remember. But look after yourself during exam season. Good luck. Don't worry about opthal. Just recognize the basics and it will set you up well for being able to differentiate and at least cross out some of your options in your multiple choice questions. Overall, you'll be fine. Don't stress. Good luck.